Hi, my name is Peter Sloan. I'm a pulmonologist from Baltimore, Maryland, and this is the first of 3 in a series of talks on acid-base interpretation. My residents and students have found this talk helpful to them at noon conferences, and I hope you feel the same way after completing. Rather than focusing on formulas and rote memory, I emphasize the importance of understanding the underlying relationships from first principles. Along the way, I'll be presenting you with some problems that are increasingly more challenging, starting with simple single acid-base disorders and ending with complex or hidden disorders. Although you may consider taking a passive approach to these video clips, I encourage you to pause the playback at each problem and solve each of these problems before I review the answer. This active approach to learning will make these discussions more valuable to you. Finally, I encourage you to check out my series on PFT interpretations that I hope you will also enjoy. Just search YouTube for PFT interpretations and you should be good to go. Now, let's get started. I want to go over the goals of today's first discussion and then the subsequent other 2 talks I have posted on YouTube. Today's talk will show you how to identify simple single acid-base disorders, understand appropriate acute and chronic compensations to single disorders, and discern differences between uncompensated, acutely compensated, partially compensated, and fully compensated disorders. In the other 2 talks, I'll go over double disorders, hidden and complex disorders, and how to utilize the patient's history to more accurately identify acid-base disorders. All of this, I hope, with no formulas, with perhaps one exception. Now, our hospital has a certain convention for listing ABGs that I'm going to stick with in this talk, but I want you to know that not all institutions use the same convention. Specifically, we list pH and PCO2 first, followed by PO2 bicarbonate saturation. I have the normal values listed over here. I'm not going to read them. And I have an example, but I want to point out throughout the entire discussion, I'm not going to label any of these values. So clearly the first value is the pH, the second value is the PCO2, etc. The final point I want to make is I'm simply placing an 80 in the PO2 spot and a 98 in the saturation spots just as a placeholder, because that's how we're used to looking at blood gases. And I'll let you know that we will not be going into oxygen exchange in this talk. It's beyond the scope of an acid-base talk. So let's start with how do we identify a simple acid-base disorder. This is something certainly medical students and beginning interns should be able to do in their sleep. First, we start with pH. We'll look at a pH, and if it's close to normal or in the normal range, we can assume there may be no acid-base disorders or 2 acid-base disorders. Generally, a single acid-base disorder makes the pH abnormal. So if you have a normal pH, we would think there is not a single disorder. Of course, if the pH is high, it means we have an alkalosis. And a pulmonologist tends to look at the PCO2 next. That's why we like PCO2 second in the order of listing blood gases. A low PCO2 shows that the alkalosis is a respiratory mechanism, and a high PCO2 shows it's not a respiratory alkalosis, and we can infer it's a metabolic alkalosis without even looking at the serum bicarbonate level. If the pH is low, we know we have an acidosis, and we look at the next value, PCO2 being elevated shows it's a respiratory acidosis, and the PCO2 being low shows that it can't be a respiratory acidosis, so we can infer that it's a metabolic acidosis. So we actually now look to see how we compensate acute respiratory disorders that are single disorders. So a respiratory alkalosis acutely drops the bicarb a small degree. A lot of our residents and students actually do not think there's a change of bicarb acutely, but I'll show you why that this really does happen. A good rule of thumb is every time the PCO2 falls 10, the bicarb falls 1. So in this example, the PCO2 has fallen about 14, so the bicarbonate has fallen from around 24 to 22, around 1 or 2. So the bicarb tracks the PCO2 acutely, and in just a minute I'm going to show you how that happens. The opposite's true for respiratory acidosis. As the PCO2 rises, there is a small rise of the bicarb. Again, 1 rise of bicarb for every rise of 10 of PCO2. So in this example, the PCO2 has gone up by 30, so the bicarb goes up by about 3, from 24 to 27. So you wonder, I thought it takes time for compensation. The acute compensation does not require time. It's part of our buffering system. This is our carbonic acid buffering system. As CO2 rises, it's dissolved in water. It goes through carbonic acid and dissociates into hydrogen ion, which does change the pH, as you know, towards a lower pH, and raises the bicarb, which is our buffering system. So this is a stoichiometric push of this reaction towards the right, where the CO2 is rising and the bicarb is being pushed to the right up in real time. Does not take time. And this mechanism right here is not a renal mechanism. This is a buffering mechanism. So how about acute compensation to a single metabolic disorder? So in a metabolic acidosis, the compensation is that we drop the PCO2 to create a secondary respiratory alkalosis. And we like to use what's called the last 2-digit rule. It's a rule of thumb. It's not totally accurate. Take it with a grain of salt. But the rule is, for moderate severity metabolic acidosis, the last 2 digits of the pH are close to the 2 digits of the PCO2. The PCO2 is falling to compensate for the metabolic acidosis. So in this example, we know there's an acidosis because the low pH. We know it's metabolic because the PCO2 is not high, it's actually low. We can verify it's a metabolic acidosis because the bicarbonate is low at 10. And we can tell that it is compensated because the last 2 digits of the pH are close, in this case exactly the same as the last 2 digits of the pH, and the PCO2 are the same. So let me say that again. The last 2 digits of the pH are close to or the same as the last 2 digits as the PCO2. Now, for more severe metabolic acidosis or extremely mild metabolic acidosis, the 2-digit rule doesn't work. So in this extreme example where the pH is terribly low, there's an extremely severe metabolic acidosis. The last 2 digits of the pH are nowhere near the 2 digits of the PCO2. Definitely don't use the 2-digit rule. It doesn't work for severe metabolic acidosis. We could use Winter's formula. I hope I have it listed, but I'll just say it. I don't like formulas, but the rule for Winter's formula, if you want to write this down, is that in a metabolic acidosis, the PCO2 rises until it's within 2 of the bicarb times 1.5 plus 8. So it's the bicarb times 1.5 plus 8. In this case, 3 times 1.5 plus 8 is 12.5. And this is 12, is within 2 of 12.5. So in severe metabolic acidosis, the bicarb will fall, the PCO2 will fall to compensate until it's within 2 of the bicarb times 1.5 plus 8. In metabolic alkalosis, the compensation could be a rise in PCO2, but that's unpredictable. Some people have a metabolic alkalosis and their PCO2 doesn't rise at all, it stays right at 40. Other people have a modest rise. Almost no one will rise much beyond 50 or 55. That's about the limit. The idea behind this is that the metabolic alkalosis will cause some respiratory suppression because the pH is high, and that will rise the PCO2, which helps compensate. So I actually do have the formula for Winter's prediction here. I wasn't sure it was coming up on the slides, so I've written it here. PCO2 will fall until it's equal 1.5 times the bicarb plus 8 within 2. And for moderate, don't forget you can use the last 2-digit rule. Very, very good rule of thumb. So let's talk about how do we chronically compensate a respiratory disorders. How are respiratory disorders chronically compensated? We've talked about acute compensations. So let's start with respiratory alkalosis. So if we have a chronic respiratory alkalosis, we're going to compensate it by dropping the serum bicarb through a renal mechanism. And a very good rule of thumb is we correct the pH almost back to normal. What would have been a high pH from chronic respiratory alkalosis, the pH comes from a high value, let's say 7.5, back towards 7.4, but not quite there. I always use a place value of 7.43 as a typical place where the pH lands in chronic respiratory alkalosis. So, as an example, this is a slightly alkalotic blood gas. pH is a little bit higher than 7.43, and it looks like a respiratory alkalosis because the PCO2 is low. The bicarb is low, and I believe this is from compensation. This is a renal compensation. It's well beyond the acute buffering compensation from the carbonic acid system. And because the pH has come almost back to normal, we can safely say this is a chronic compensated respiratory alkalosis. The opposite's true for a respiratory acidosis. Chronically, we're going to compensate by rising the bicarb above normal through renal mechanisms until the pH comes up from a quite acidosis value, an acidotic value, towards but not all the way to normal. 7.37 is a typical value in chronic respiratory acidosis. Here's an example. 7.37, slightly acidotic. PCO2 is very high at 70. The bicarb has gone up just enough to make the pH come almost back to normal. This is an example of a chronic compensated respiratory acidosis. So what's the compensation to a chronic metabolic disorder? Well, since the chronic metabolic disorders compensate immediately within a few minutes on a respiratory basis, there's really no difference between the chronic compensation to metabolic disorders and the acute compensations. So if you know how an acute metabolic acidosis compensates, that would be the last two-digit rule or Winter's rule, or if you know how an acute metabolic alkalosis compensates, that's from varying degrees of CO2 retention. The rules are the same for chronic. There are no separate rules, so these are quite easy. So now we talk about degrees of compensation. You can diagnose a single disorder, but there's no guarantee it will be compensated. So we've already discussed acute compensation, what happens acutely, and we can discuss the concept of uncompensated. If you diagnose a single disorder and the opposite system hasn't made a change, then it's uncompensated, meaning in a metabolic disorder, either metabolic alkalosis or metabolic acidosis, if the PCO2 has not changed, that would be uncompensated. And in a respiratory disorder like hypercapnia or acute hypocapnia, if the bicarb is still 24, then that's uncompensated. So there's more degrees of compensation. There's fully compensated, which we've started to discuss. In respiratory alkalosis, we know when it's fully compensated, the pH is close to 7.43. It doesn't go all the way back to normal. We've discussed in respiratory acidosis, the pH is 7.37. We've discussed in metabolic acidosis, the pH doesn't necessarily go all the way back towards normal, but in the case of a metabolic acidosis, we already discussed how the two-digit rule is in effect to see if it's fully compensated. And in metabolic alkalosis, it's fully compensated when the pH is near 7.43. So of all four of these, the only one that doesn't go back to a near normal pH is metabolic acidosis. When there's a severe metabolic acidosis, the pH can be quite low, even if there's full compensation. Partially compensated is the only one we haven't talked to, but it's very easy to define. If it's somewhere between not being compensated and being full and compensated, then it's partially compensated. So you can detect some compensation, but that falls short of full compensation. All of these are very tricky concepts to understand without examples. That's why I've already started to give you some examples. But as I give you more problems and examples, you'll really understand this. So we're going to do our first problem set. And I'd like to pause just to remind you that this is where I mentioned active versus passive learning. I'm going to show you a problem. Here's the first problem. This is where I'd like you to pause the playback and think about the answer, write down the answer, and then listen to the playback. On the next slide, I'll give you the answer key, but it's not a good idea to just run the video continuously and listen to me, because you're never going to be able to learn it unless you try these problems yourself. So pause, and when you're ready, unpause. Okay, so let me solve the first problem now that you've solved this on your own, I hope. This is an acidosis because of the low pH. The PCO2 is high, so there must be a respiratory acidosis. The PCO2 is 50 above normal, and the bicarb is about 5 above normal. So I know the bicarb has gone up about 1 for every 10, and this is what I expect as acute compensation for acute hypercapnia. So this is an acutely compensated respiratory acidosis. This is through the buffering system. This does not imply any chronicity. This does not imply any renal mechanism. This is just how we buffer acute rises of PCO2. This is a single disorder. Problem 2. This is also an acidosis. I look at the PCO2. It's not high. It can't be a respiratory acidosis, so I've diagnosed metabolic acidosis. Metabolic acidosis is shown by the low bicarbonate. That's lower than 24, so I've confirmed my suspicion. Now I need to see if it's compensated. Two ways of knowing. It's a moderate severity metabolic acidosis. The last 2 digits of the pH are close to the PCO2. That's my 2-digit rule, so I believe it's compensated. That's my quick and dirty check. But if you want to be sure, do Winter's formula. Bicarb of 11 times 1.5 is around 16.5, plus 8 is 24.5. I expect the PCO2 to be within 2 points of 24.5, and it is. So by all criteria, this is a chronic compensated metabolic acidosis with a respiratory compensation, and this blood gas is a single disorder. Okay, just reminding you to pause your playback. Now unpause. This is an alkalosis. It has a low PCO2, so it's respiratory. The PCO2 is down about 10 or 20 below normal, about 15. The bicarb is down about 2 below normal. It's in the ballpark of 1 change for about every 10 change. So this is an acute respiratory alkalosis. And again, this is a buffering system thing, not a renal thing. It's a single disorder with acute compensation. Here's another blood gas. If you can just pause and unpause. I'm going to stop telling you to pause and unpause. That's up to you from now on. But please remember, that's what I recommend. Alkalosis, it's a high PCO2, so it can't be respiratory. This is a metabolic alkalosis confirmed by the high bicarbonates. And because the pH has started to normalize towards 7.43 by a respiratory compensation, but the pH hasn't gotten all the way to 7.43, we'll call this a partially compensated metabolic alkalosis. Okay, you should be back from pausing. This is a slight mild acidosis, very high PCO2, so we think this is a respiratory acidosis. And the compensation is metabolic, so this is a primary respiratory acidosis. Now, because the pH has come close to normal at 7.37, but not all the way back to normal, this is a compensated chronic respiratory acidosis with metabolic compensation, also a single disorder. Problem number 6. This is an acidosis. I hope you paused. Acidosis. It's not respiratory because the PCO2 is low, so it's a metabolic acidosis. However, the last two digits are nowhere near the PCO2, and in fact, if you look at Winter's formula, the PCO2, if it's compensating a bicarb of 10, should be 10 times 1.5 plus 8. It should be 23. So the PCO2 hasn't gotten down to 23, but it has moved down from 40 to a degree. So it's partially corrected. Instead of going all the way down to 23, it's corrected partially. So we call this a partially compensated metabolic acidosis. Here's a slight alkalosis. It's a low PCO2, so it's a respiratory alkalosis. The bicarb is low to compensate, and the pH has come almost back to normal. So we'll call this a completely compensated respiratory alkalosis. Last blood gas in this problem set. Extremely severe acidosis. Bicarb PCO2 is normal, so it can't be a respiratory acidosis. But of course the bicarb is low, so this is a metabolic acidosis. Since the PCO2 hasn't changed, this is an uncompensated metabolic acidosis, and as a pulmonary critical care physician, I can assure you this is very bad for your health. The reason is first of all, we depend on the respiratory compensation to keep us out of trouble when our bicarb goes low. Second of all, we always wonder, why is the patient not having secondary alveolar hyperventilation? This is really a form of respiratory insufficiency. When the PCO2 is 40, it's usually a sign of impending respiratory failure, and we do intubate people who have metabolic acidosis and are unable to compensate, because it's very dangerous when we lose our respiratory compensation. It's usually a sign of diaphragm pump failure. So all 8 of these problems are actually single acid base disorders of all types with varying degrees of compensation. So here's the answer code, just to have for your records. And that ends the first of 3 talks. I think that's the longer of the 3. So if you can join me on the other end, and we'll continue with talk 2. And I want to remind you, I have some very nice pulmonary function test talks posted to YouTube that our residents and students also enjoy, if you want to check those out. I hope these are helpful to you. Thanks.